Thank you very much, Harold. I wish I was about 6'4", that way I could straddle that trap door. But thank you very much for the opportunity to be here. We'd like to tell you a little story about one group, the State Employee Health Commission, and I'd preface that by saying that I have been, for the first 25 years of the Health Commission, I was either a co-chair or executive director, which meant that over that time I became the repository of a vast amount of irrelevant knowledge. But I also had a chance to get to work with this labor management organization that, in retrospect, extremely proud of that association. For Maine, this is a big plan, covers 40,000 employees, retirees, and dependents statewide. And it's comprised of the actual plan participants. Naturally, we have to have a forest ranger since we're in Maine. And these folks represent their broad constituencies. They have day jobs, but they became, over time, very sophisticated and extremely strong advocates for their constituents. They have complete authority over the benefit design and the plan design. And they were really activated 10 or 12 years ago by a series of things, the IOM report, the development of Leapfrog, and a lot of internal analysis of the huge variation that we saw within our plan in terms of cost, quality, and utilization. And I think they showed their advocacy for multi-stakeholder participation by being a founding member of the Maine Health Management Coalition. So early on, they became convinced that there's these huge gaps of care and that something had to be done to improve the value of this significant investment that the state and the employees were making in benefit coverage. The current fee-for-service system just had all of the wrong incentives. They recognized that, but they also recognized it was going to be very difficult to turn that around in a short period of time. There were going to have to be some incremental steps that would have to take place to make progress. So in 2005, they adopted a value-based purchasing strategy, which in retrospect doesn't look all that radical. As we want to encourage our members to make informed decisions about their health care, we want to provide some modest incentives for them to seek higher value care, and we'd like to reward the providers who can demonstrate that they deliver higher value care. We targeted hospital tiering initially, and the objectives, again, in retrospect, weren't all that radical. We wanted to encourage public disclosure on the part of the providers, establish performance measures with the forewarning that they would be incrementally expanded and adjusted. We would raise the bar, so to speak. We wanted to drive safety and quality improvement, give our members some basic tools to make decisions, and offer some very modest incentives to change their behavior and shape their decision-making. So the first phase of the hospital tiering was in 2006. No matter whether it's in retrospect or not, they were very modest benchmarks. All we were looking to establish was that the hospitals met the national average for the CMS core measures, that they merely completed the Leapfrog Safe Practices Survey, and that they had demonstrated good progress on an internal Maine Health Management Coalition medication safety survey. So that was using those different sources. What really helped was it activated and catalyzed the formation of the Pathways to Excellence steering committee dealing with hospitals, which now has morphed into a systems review. And it meant that it brought a multi-stakeholder voice at the table: health plans, the providers, the purchasers, and the hospital representatives. So the early results were fairly substantial. We were the first group to do this in July of 2006. Remarkably, only 14 hospitals met that very low threshold. And it caused a lot of consternation, as you might expect, out amongst the field as we went and explained this new benefit design. By January of 2007, all main hospitals were reporting to leapfrog. All main hospitals were participating in the coalition's medication safety program, and lo and behold, the number of preferred hospitals went from 14 to 25 in 6 months. And we'd like to take credit for that, but actually it was our members who drove that change. They were the ones who went to their local hospital executives and said, "You mean you're not a preferred hospital because you won't disclose your performance?" And that was a pretty hard sell so we saw this dramatic turnaround, and we also, very encouragingly, saw a 5% shift in that first year in outpatient services from non-preferred to preferred. And there was an evolution. The next year, the commission was somewhat energized and decided, let's take the same principles and apply it to primary care practices using the coalition's Pathways to Excellence public reporting for a series of clinical measures and office systems. New incentives were introduced over the course of several years, as well as new measures. The one that caused, and Barbara will speak to it, I'm sure, that caused the greatest consternation was in 2006 when the HCAHPS patient experience results were finally reported, and we began to use them as part of our overall tiering. We increased incentives over time, made it more meaningful for employees to make that choice, but also expanded the opportunity for hospitals to participate. In 2011, the commission had to make a fairly significant course direction change. Everything had been predicated and sold to the membership, to the providers, on quality and safety. There was no cost in the equation whatsoever. However, in 2012, the legislature enacted a biennial budget which flat funded the program based on the prior year, fiscal year's spend. And our analysis of our claims showed that we were looking at about a 10% expected trend for the upcoming fiscal year, and most of that was being driven by provider inflation, and the vast majority of that at the hospital level. So the commission decided that they had to take, after forewarning to the hospital community for several years, that we were going to have to come up with some cost methodology, and if we couldn't collaborate on one, we would seek another source, which is exactly what they did. We used, another nonprofit organization, which had been at that time a data warehousing partner with us, changed the weighting formula so that cost became as critical as clinical quality and patient safety. Had to introduce, in order to meet that flat funding, very significant and meaningful incentives. Went far beyond the modest phase into the almost punitive, because of the $22 million reduction in overall expenses that the plan was facing. But the commission also felt impelled. We had a budding relationship with Maine General Health, which Dr. Crowley is going to speak to, which is located in Augusta, their main campus, the capital, where about a quarter of our total spend can be attributed. They had made an overture to the commission about partnering, and in turn the commission said, let's invite any health system or hospital or physician practices, for that matter, to come forward with bona fide payment reform and delivery system reform proposals. We'll consider them and start altering how we define the preferred hospital criteria. But there's got to be two actually criteria. One, you still have to meet all of the clinical quality and safety components of the criteria. And number two, whatever proposal you bring forward has to include some sort of risk arrangement. The employers, the purchasers, are simply, their patience has been expired, in terms of continuing to absorb risk for hospital systems and other providers to explore delivery system change. So the key takeaways, I don't think are probably all that profound. You've heard, about the reliance, excuse me, on data that has become so imperative, certainly in our discussions with Maine General and other providers. The idea of working with the provider community, I think we heard it at least once earlier this morning, the providers and the purchasers looking and examining at how you can modify the benefit design so it makes sense for the delivery system and payment reform changes that you're trying to make. That's still evolving. And I can't emphasize from the employer perspective how important it is to invest in member education. You have to make the benefit design and the shift to system reporting relevant to them. Otherwise, it just seems, so totally foreign to what they've been accustomed to. And it took a large investment in resources, time, energy, and staff to go out there and do each phase of this tiering initiative and the whole value-based benefit concept. But without it, we wouldn't have been able to have stories that Harold always likes to hear about. And my favorite one was in Holton, which is way up in northern Maine, throw a rock and you're into Canada. The employees contacted us and said, we have, our hospital hasn't made the preferred hospital list the last 2 times. Can you explain what the problems are? So we shared with them that they had failed to meet some of the protocols for medication safety administration. And armed with that, they went and met with the local hospital officials who really kind of summarily dismissed them and patted them on the head and said, we can't invest in all that. So they came back, got some additional information from us, and in the interim, they found out that Holton Regional Hospital had a certificate of need application pending for a capital expansion, and they went and petitioned the Department of Health and Human Services for a public hearing and went in and made the case. They said, how can DHHS approve capital expansion of this magnitude when our local hospital can't meet basic safety for our constituents and the rest of the community? And they ended up getting a resolution. The CON was conditionally approved pending implementation of the adjustments for medication safety on after duty. And it was just a wonderful story of how empowered consumers, if they're engaged in the process, armed with some information, they really can be incredibly powerful advocates. And last, it shouldn't be any surprise that going from, it's one thing to coax providers to work together to improve quality and safety and patient experience. It's much more difficult when cost gets into the equation, because now they're starting to worry about market share, understandably. Thank you.
Thank you.